Right. Well, good morning, everybody. Thank you for joining today. I think we're going to talk through the agenda, and different people would talk at different times. I'm just giving it a head start. Um, Pharmacists and medication technicians that will be watching this later, if you have any questions, you can reach out to me. The agenda is on the chat, so that will be visible to you even later. And the documents that we talk about today, I will share it over an email. So we will be good with that. So I think first thing on the agenda is why simulations, and I can briefly talk about that. Basically, we have realized and got the feedback over the last few months while engaging with health plans. Who wants to talk? So while engaging with different health plans, we've realized that since we're not in a continuous engagement right now, that at times it might be hard for pharmacists or medication technicians to remember how we do stuff on the platform, or what the process is for MTM, what the timelines are. So to just keep each one of us reminded of how to do stuff and get better at it and become experts at it, it will be great if we can do that over a period of time, even before clients are assigned to us. So simulations will be kind of a way of getting clients assigned to each and every pharmacist and pharmacy medication technician, so we can practice that as we go along the way before we get real clients, which might be shortly down the line as we have HSC pediatric and other plans coming up with our to be contracted with us. I think for the simulation documentation, I can pull up the document, Dr. Keys, that you have commented on before, and if you could take us through that, that might be helpful.
Absolutely.
Yep, here's the document. I can make it a little bigger if it is. Okay.
Okay. So fundamental to the MedNovate Connect success is really the performance of the team that services the enrollee. Everything else we do hinges on the actual quality and professionalism and impact of the work of the medication history technician and the clinical pharmacist and our team that supports them. And so the impressions that we have are going to come from doing it well and doing it better over time. So I make this statement at the beginning, particularly so our medication history technicians and our clinical pharmacists remember their key role in the performance of this service. It's something that's exciting, it's really impactful, and only by the enrollees experiencing all the work that we put into this and all the training that each of you have, that is going to be evident and sustainable in the healthcare marketplace. So we use simulations for things like codes. We in the hospital, things that we don't do often to keep people functioning as teams and completing things in a competent fashion. And so that's how we've adopted it for this forum that we're in now. As we engage more enrollees and more clients, and simulation will become less and less necessary, but let's just speak to it for the moment. And I'm doing it also with the perception that I actually went through the process. I'm actually an enrollee, I'm onboarded, and I'm in the MedNovate Connect platform. So the participants is the PharmD and the medication history tech for the simulation, as well as we have requested our two of our team members from the administrative staff, Ms. Calienta and Ms. Darcy, to serve as actors vis-a-vis enrollees, non-clinicians. So that the resources that are necessary to perform the simulation include smartphone, which is what the client actors, our administrative staff are required to have, and then our clinical team who work on the web platform on the PC. We do recommend some preparatory reading material specifically for HSC Pediatric Center, which is a pediatric hospital that has some unique diseases and has some very special handling of medication in the pediatric patients. And so at the bottom of this simulation. It's recommended, wouldn't say it's required, because if you already have a good handle on medication safety and focus on pediatric patients, then you don't need to do this. But if you do not, then you should take this as a requirement. Thank you for scrolling down for that. We have 3 actual cases from HSC Pediatric Center that were prepared by the clinical pharmacy coordinator there, Dr. Mandana Iman, who's a PharmD, who has worked with HSC Pediatric Center for over 20 years, and who selected these cases because it's illustrative of the kinds of medications and the kinds of disease conditions and circumstances that we will encounter in the enrolled HSC hospital discharging individuals. So there is, to complete the content, there's a list of discharge medication regimen, along with the indication for use to be provided to the clinical team. So that means the med history tech and the clinical pharmacist will know the list of discharge medications in this simulation. There are patient demographics, a problem list, and sometimes drug allergy history, which will be provided to our administrative staff serving as actors. They will have a copy of this information, as well as they will have a copy of the medication list with the indications, meaning why the patient is taking the medicine. I didn't say, but remember, HSC Pediatric Center is for children. They're as young as first year of life, and they can be as old as up to, I think it's 23 years old. So it's a wide range. The clinical team, the clinical pharmacist and the med history tech should have knowledge of and access to the Dr. First database. We know that in the model, the med history tech will be the primary user of the Dr. First database for double checking the list. But we need the clinical pharmacists to know how to use it as well, because you ultimately are responsible for this activity. We also have CRISP access, and so that is only for the clinical pharmacists. You're supposed to be licensed to access CRISP, and that is a data source that we've been sharing through, Sneha's been sharing that access point for the clinical pharmacists. And if there's any problems, she can link me in. I'll be happy, or several of us, Dr. Deli, Dr. Zeman, are able to facilitate with you on that. The
Yeah,
drug claims, go ahead, please.
Dr. Keys, if I can interject just for a moment, I think both for Dr. First and CRISP, all our pharmacists need to reach back out to me, because we have been working on getting that access for a long time, for a few months now. So we need to close that soon. So at whatever point you're listening to this recording, I would request you to look at where you are at individually from your CRISP access point. If you don't have the access, please reach out to people at CRISP and get the access done. If you're having any problems, please reach out to me, because we need to get this sorted soon.
Thank you. And Dr. First, if anyone doesn't have access to Dr. First, it should not be a problem. Patty Carmody is an authorized administrator to put someone on, and I'm an authorized administrator. I don't remember, not to say how if you are, but I know Patty is, and I am. So, and it's quick and should be relatively easy. Okay. And for both of those data sources, there is a training video. So you can self-learn if you have not ever used it, but by no means should you be doing this work and not know these 2 tools. And I have no problem if you have to call me as well to our team. The drug claims history from HSCSN. So you know that our client is HSCSN, that's the Health Services for Children with Special Needs. It's a District of Columbia Medicaid funded program for children up to age 25, if I'm not mistaken. Right now, Dr. Deli has not gotten continued access. She has, I think, been on it, but we will be getting access to that. And what that simply means is CVS is the PBM, the Pharmacy Benefit Management of record for that insurance company, and anything that's paid for by that insurance company for that enrollee should be on the CVS list. And so, and we will find out how much of Dr. First data captures that as we enroll our enroll people into the program. So simply put, the drug claims history and Dr. First, and then any list that you have from the enrollee or their family member coming out of HSC or from anywhere else are your sources of medication history, along with the interview with the patient and family. Post-session evaluation tools. Sneha, you may want to speak to this instead of me.
Yeah, I think Kenan and I will have to formulate a plan for the evaluation tools, and we will share that soon.
Okay, so there'll be 2 evaluations. We'll be looking for Heliantha and Darcy when you're actually playing as the patient / mother or father for the child. Then you will be asked later about your experience with having received the service from our clinical team. And then the clinical team will be asked to give feedback about their experience. The schedule of the cases, which is to be determined, but the basic plan is that we are hoping for there to be more enrollees soon, but each clinical pharmacist will perform a new case every other week for 2 cases over 4 weeks. So within a 4-week period, 2 cases will be done. These are simulated cases. The med history tech will perform every other week for a minimum of 2. And if it's the same med history tech for all of them, then you'll be twice as busy, if you will. On the week that the clinical pharmacist is not doing a simulation, they're to conduct one of the following activities: initiate a chat with follow-up to the enrollee. So Heliantha or Darcy, you should get a chat on your app from the clinical pharmacist in relations to the initial session. There may be a second video appointment that's set up with the enrollee, so you learn how to do that if you don't know. And that can be a short one. And we will verify this, and I know, Sneha, you were not sure of this, but when I recalled the app functionality, and I am on the program, if I put in a drug and then I put in another drug that's a duplicate, then an alert comes up on my phone as a patient. That same alert is supposed to go to the assigned pharmacist.
That's right.
And so, okay, and so the other part for you as the clinical pharmacist is if we're going to simulate so that Darcy or Heliantha puts in an intentional problem medication. You also should see that as the clinical pharmacist, and you should respond to make sure that there's some meaningful follow-up and that something bad didn't happen in spite of the alert. That's the purpose of the simulation. And then number 5 is review of the simulation. That's us just revisiting it to make sure we can update for the future. And the review, that's primarily Dr. Sneha and the executive team, which Ken would lead, and others would participate as needed, but Ken and Sneha will do that. So those are the elements of the simulation. We think it's really important that it's done well. It's an opportunity for everyone to understand the process as well as and for the clinical team to get some real world experience, because they may be a simple case, but most of them are not. And so we need to be clinically aware and ready and engaged. And I did not include Dr. Madonna in this simulation other than she shared the cases, but she will be our resource person because she is the expert from that facility if we need to bring her in to clarify anything for us.
Thank you, Dr. Hughes. Yep, this document I will share with everybody over email after this meeting, and you can review it. If you have questions, get back to us. And then Ken, I think next thing on the agenda is the remuneration for the simulations. If you can talk about that, that would be helpful.
Yeah, thank you. As Dr. Keys and Sneha were mentioning, this is to help get people prepared, not only clinically, but also with the app, so that there's, a seamless and gives you some experience with that part of the process. We will be remunerating the pharmacist and the tech. For the pharmacist, there'll be a one-time remuneration of $75 per patient. And so having done this, you'll be reimbursed for that particular patient. So if you do 2 patients, 4 patients, et cetera, it's $75. For the tech, it'll be $25 to be remunerated to do the simulation. We think that it will take your time and effort. So not only will you be getting experience, but you'll be getting some reimbursement for that.
Perfect. And any other thoughts that you want to share about?
No, I think that this is a way for us to have a better service and a better product. So we would, I don't know if you mentioned this, Dr. Gawali Keys, but we would like feedback on the app. And this will be a chance for you to work with the app more intensely than you've practiced before. And so that'll be helpful, because if there are issues that come up that one might need explanation, or we may need to adjust or fix the app, we would really be benefit the whole program if we got that feedback. And again, no question's a dumb question. We need to just be very comfortable with it, because that's going to be the success of the program, is not only how well the pharmacist and the tech use the app, but also how they can guide the patient in that. And then how we can support. There may be questions and things that come up, and you might say, hey, how do I address this? And we can then decide what kind of support systems we need to put in place for that.
Absolutely, I agree. Yes, I will share probably a spreadsheet that will have a space for all of the pharmacists, medication technicians to put in their feedback, whatever kind that might be, so we can record it and we can follow it up to make sure that it's seen through to resolution or a new system or whatever that might be. And then for Darcy and Helianta, who will be the acting enrollees, also can share their feedback on that same spreadsheet. So I will do that shortly. Thank you, Ken, for that update. And then the remuneration part, of course, is for MedNovate Connect contracted pharmacists and MedNovate Connect contracted medication history technicians. Another thing to note, that we were calling medication history technicians pharmacy technicians before, but we have done like a rename to this role, and it will be called medication history technician going forward. So please take a note of that for Jolie and Dilsani. Moving forward, a good update is that we have started the new HSC pediatric discharge program, which is a HSC pediatric facility, and any and every clients that go through the facility are admitted to the medical center hospital. When they're discharged, the case managers and nurse practitioners that help with the discharge planning are now going to take up the role of sharing with clients and their families about the help that they can get through the MedNovate Connect program. So we've already initiated that, kicked it off, and the referral process and everything is is already moving forward. So you can expect, as pharmacists and medication history technicians, to get enrollees through that program as well. So as of now, we might have people that come through HSCSN plan, which is just the health plan, and anybody that is on the health plan can be referred as an enrollee to the program. And as a parallel to it, we have HSC Pediatric Discharge Program now, which is kind of under that umbrella, but slightly different, because these might be people that are admitted to the hospital and get referred to us. So for the pharmacists and technicians, not much changes. The process remains the same. We have added some timelines. Here's a flow, which might look complex at the look of it, so don't let it worry you. It's not complex, especially for pharmacists or technicians. I'm going to go through it very briefly. Whenever we receive the referral form from HSC Pediatric, the admin assistant will receive it. If the client is interested, if they have declined the service, the admin assistant will just mention it that they have declined the service, ends the process. If the client is interested in the service, the admin assistant will give a call to whoever that client is and their family. And upon calling, if they decline it after calling, it will still end the process. If they do not receive, the admin assistant will make 2 more attempts to call them before closing the case on somebody. And if they accept the service, let's say they have been discharged from the hospital and they want to enroll into our program, the admin assistant will take a note of that. And time availability tracker. So if you're a pharmacist or a technician, you know that in the last year you have given me your time availabilities on a spreadsheet for the whole month. So we have that available, and the admin assistant can seamlessly and easily, as soon as they see that you're available and that the client looks like they're in your expertise, they can just schedule you with them. So I think that's one important thing to do for the days to come as we get real enrollees from both the plans that we need. I need your time availability on that tracker. So I will share that again. If you can share your availability for March, even April, that might be helpful and make it easier rather than going back and forth between the team to get somebody scheduled as soon as possible. So once the client, if the availability tracker is available, the admin assistant will just go ahead and schedule the call with medication technician first, and then the pharmacist. The admin assistant kind of updates multiple documents. One is the discharge tracker, where we will be storing all the information for the enrollees, the time availability tracker. So if Darcy or Helianta have scheduled somebody, they will mention who scheduled, the name of the client will be mentioned in the spreadsheet at the date or time that's assigned to you. And if you have, I think you've seen it before, so it shouldn't be confusing. If it is, get in touch with me. And she will send a confirmation email to the client saying they have been scheduled with the medication technician. So once the medication technician is assigned, they will go through, I think Dr. First is what we're talking about for both medication history technicians and pharmacists. So they will look at the doctor first, make sure we have medications list or whatever information they can gather from that, and then meet with the client the day of the appointment. Day of the appointment, as normal, Dilsani or Jolie, you've done that before. You have onboarded clients, you've onboarded Dr. Keys as a client. Yep, I can send you the link of the flow chart, not a problem. And thank you for joining us. I appreciate it, and we'll talk later, not a problem. Yep, so for medication history technicians, let me gather my thoughts back. Dr. First Access, I will get in touch with you if you don't have Dr. First Access, and I think we can just get that done with Patty Carmody or Dr. Keys. So the normal onboarding process from here starts with the medication history assistance, and you've done that before, like I said before. Just onboarding the client on the platform, getting excuse me, the client's profile created, getting all the medications listed on the platform so it's all ready for the pharmacist and the clients to use the app. So once the medication technician is done with that, they can just update a Teams folder, and all of those are mentioned over here. And then once that is done, I will assign, or Ken will assign, a clinical pharmacist to the client, and that will be depending on the time availability tracker, the times and dates you're available, you will be scheduled with the client, and that ends our process. So hopefully I didn't talk too fast. And if it doesn't make sense, it's fine. You can read through this and ask questions. Each one of you has an access to Teams, and Outlook, and a ClinPharm ID. So you should be aware of these folders because we will be working on Teams completely. So under Teams, MedNovate Connect staff, MTM, we have all the different projects listed, and within each project, we will maintain all documents for all clients within there. We will not be emailing because that will be problems with HIPAA and security issues. So we want to make sure that you are aware and you look through Teams. Again, I can help you set it up if you don't already have that. So this is the new piece to this whole process. Is that the first call initiation should take place by the admin assistant, either Helianta or Darcy, within 24 hours of receiving a referral. the assigning of medication technician. Let's say Darcy calls somebody and the client says, yes, I would like to meet with them. The medication technician should be assigned within 24 hours. And the pharmacist assignment will take place once this could happen even while the client is being onboarded. If you have time availabilities from the client, then in the first 5 days, within 5 days, we should be able to, 5 working days, assign a pharmacist to the enrollee. And we have put these timelines in place so that nobody falls through the gaps, or a process of onboarding a client does not take too long. So we're going to try to comply with the timelines that we have mentioned. And then Darcy, Bryant, and Helianta, who are on this call today, if you haven't met them, they are our admin assistants at the CPA Laurel office. They work physically from there, and Darcy is on office from on Tuesday, Wednesday, and Friday, and Helianta is there Monday, Thursday, maybe Friday as well. And those days I've mentioned just because we will receive these enrollee referral forms through fax, and different people, whoever's there, will check the fax and complete the loop for the client. So I will share this document as well. Yeah, other than that, I think that kind of sums up the agenda. But Dr. Keys, any thoughts or feedback before closing?
For the medication list, we have Dr. First of the patients. We have potentially, we will have at some point for certain HSC, SNs, medication, all prescriptions filled. It's possible that for some of these enrollees, we will have the ability to get a list of what they would discharge from when they left the hospital. So our med history tech, our administrative, Darcy and Heliantha, as well as our Jolene and other med history techs, be aware that a question to pose to them is, do you have your list of medications when you were discharged from the hospital?
Mhm.
Because if so, they should have that available for when they meet with the med history tech and probably with the pharmacist. I just don't know how reliable it will be. And we have not made provisions at the hospitals to have them fax that list to us. We're nervous about asking them for any more work, because generally the more work you ask hospital staff to do, the less likely they will comply with it. But we will work that through over time and figure that out. The other thing I just wanted to add, and thank you for going over that flow, and it's really very good, is that Darcy and Heliantha, you'll need to have somebody kind of go over the actual cases so that you are a little bit comfortable with expressing the information, because it is some of it's clinical information. And so I'm going to ask Dr. Raymond if you could take lead with reviewing with them the cases. That way they'll be comfortable to express those cases. Again, the med history text will not have they will have the med list, but they won't have any of the other information. And the same will be true for the clinical pharmacist in the simulation. Okay.
So, yep, that would be great, Dr. Raymond. And I think we should put a kickoff date to the simulations as well, so everybody is aware that from there they will start getting assigned to enrollees, and we can start this. So should we probably give it a week to kind of review this presentation, get aware of the process, and then maybe a week later?
Today is Friday. I think if Dr. Raymond is able to work with the admin, with Heliantha and Darcy, then I would say middle of next week to not delay, because we theoretically will have enrollees. Madonna has a patient she's anticipating being discharged soon for HSC. So if we could maybe do Wednesday next week.
Okay,
Yeah.
so Wednesday, 8th of March will be the deadline to review this presentation, get yourself acclaimed to all the documentations we share, ask any questions. If you don't have access to Dr. First or CRISP, we need to get in touch and get that sorted. We have a really tight deadline for that one now. So that's good. And yep,
I
and then
have a
offline.
question.
Yes, go ahead, Darcy.
You want us, me and Helianta, to get access to Dr. First?
No.
Okay,
No.
good.
Yep.
Okay.
But I think offline, I think Darcy and Helianta, while you work with Raymond, Dr. Raymond, if you have questions regarding the script, let me know, because I know we talked about that. So we can talk about it in the coming week.
That sounds good.
And I
And
will,
then-
I will
yep.
mention to you that we have reached out to Children's National Medical Center now. We're waiting to hear back from the Director of Case Coordination. And so again, we don't know what's going to happen exactly when, but if we get access to our HSCSN enrollees coming out of Children's Hospital, that will be potentially a much busier hospital, since that's where many of there are. And so just to be mindful, simulation now will be most meaningful to do now. Yeah,
Right,
in
absolutely.
preparation for when it starts. Yeah.
Yep, and then Children's National is DC and Maryland licenses required.
DC,
DC
it's a
mostly,
DC
okay.
hospital, so DC license. The truth is, if someone is subsequently, when they get children from all over the area and all over the nation and probably even internationally, but HSC is a DC insurance, so we're focusing on the DC licensure. Yeah.
Okay, perfect. Yep, sounds good. Yeah, that means that we could get clients through that. We need to be prepared. Yep, and then Dr. Mandana, you heard her name. She is our point of contact with HSC Pediatric, and Dr. Bamadeli Kalajaya, she's not on the call right now, but she will be our point of contact for HSCSN plan enrollees. So if you hear their names, don't be confused. But as for this meeting, we will talk later. I think thank you for watching the recording at whatever time you do. I look forward to hearing from you all.
So the meeting on Wednesday will be